Welcome to Muted in Medicine, the podcast where we break the silence on the untold stories and pressing issues within the healthcare professional. Join us as we dive deep into topics that often linger in the shadows of medical corridors and are not discussed in conferences, meetings, social gatherings, and in the hallways. They are often hiding. From navigating errors and facing litigation to the often overlooked realm of mental health among healthcare professionals. Through candid conversations and storytelling, we aim to amplify the voices and shed light on challenges that resonate across the medical landscape. So grab your stethoscope and a cup of coffee and tune in as we uncover the layers of complexity in the world of healthcare that are so muted, yet so profoundly impactful.
Hello, everyone, and welcome back to Muted in Medicine, the podcast where we break the silence on untold stories in healthcare. My name is Saba Fatima, and I'm your host for this podcast. I'm a pediatrician with a passion for helping healthcare professionals facing secondary trauma at work in healthcare. If you're liking our content, please subscribe to our YouTube channel and give us a review on Apple or Spotify. Some diagnoses makes clinicians uncomfortable. Not because they are rare, but because they live in the gray spaces of medicine. Munchausen by proxy, also known as medical child abuse, is one of them. These cases challenge our instincts to trust caregivers, test our systems, and leave healthcare teams carrying fear, doubt, and moral distress. The stakes are high: protecting a child, avoiding harm to families, and navigating legal and ethical complexity, often without clear guidance or support. In today's episode of Muted in Medicine, I'm joined by Dr. Gill to unpack what medical child abuse really is and what it is not. We talk about recognizing patterns without bias, navigating uncertainty, working within multidisciplinary teams, and caring for ourselves and clinicians as clinicians when suspicion alone can feel destabilizing. Dr. Gill, also called Dr. Bex, is a pediatric hospitalist at Nemours Children's Hospital and assistant professor at the University of Central Florida College of Medicine. She is a nationally recognized expert on medical child abuse, a recurring contributor to the podcast Nobody Should Believe Me, and an advocate for victims and survivors through her work with the APSAC National Subcommittee on Munchausen by Proxy and the nonprofit Munchausen Support. I'm grateful for her to be here on the show. Dr. Bex, welcome.
Thank you so much for having me. I feel like when I saw you and kind of realized what you were doing, I feel like we focus a lot on maybe like how to manage this, which I think is so important, but added into that is kind of how much it impacts us as physicians and not just us, every provider, everyone who is involved in these cases, in any role. And I think that's what I try to bring in, like when I'm presenting, is talking about what it is, but also talking about kind of how we can work better, I think, as a system and work better in protecting ourselves when we are dealing with these difficult cases.
Yeah, and that's so important. And I think that's the premise of this podcast too. So yeah, I'd be excited to dive into that piece. First, before we start, though, we ask everybody what's bringing you joy in medicine today.
Actually, I will say it's funny you ask that because I just got asked at the end of one of my talks and it completely threw me off. But someone asked me, do you have hope? And It was interesting because often it's hard to not focus on the negative when we talk about these cases because often the outcomes are not always what we wish or want them to be. And so I think what gives me hope is that people are talking about it. And that also brings me joy. Like every time, as much as I don't want these cases to happen, when a resident, when a medical student, when someone comes up to me and says, I have a question about this case. And it may be something very minor, but at the same time, people are talking. And when I talk to survivors who are doing well, when the case that actually brought me into all of this did have as positive of an outcome, I think, as we can find in these cases, that's what I try to keep going back to. And every time I go present at a conference or meet people, it's kind of the nodding heads in the room. It's that people finally feel like they weren't the only one who felt that way, or that they were alone when they were in one of these cases. So I just love meeting people who say it's nice to know that somebody else gets it. And this team of people I get to work with every day. I was just on a meeting for the nonprofit I work with. It's just all of that brings me, I think, joy in medicine that we can do this better and it can actually bring people together. And hopefully, again, continuing the conversation is most important.
Yeah. And so you're a pediatric hospitalist, really. So I'm assuming you didn't start out with this. So what got you interested? I know you mentioned something about that.
So I actually did a year of psych training. I thought I wanted to be a child psychiatrist, which I still have a passion and a love for it. It was going to be doing all the years of adult psychiatry that was going to be probably very taxing for me. And so I ended up going back into pediatrics. So I think my part of me has always geared towards those cases that have kind of a combination of medicine and psych. And our hospital was the third one in Orlando to open. So I think we, right off the bat, had a very complex patient population. So I think we were a little bit of setup maybe to get some of these cases. But I've always been that person who digs a little deeper or looks a little harder, and I can't help it. People, like, I've had cops come up to me after talks and say, "Hey, you want to come work with us?" I'm like, "No," but I do have that there is that part of me. And so I think this really plays to that. And then that case that kind of changed everything for me. It was like multiple months. It was all encompassing, but it did have a positive outcome at the end. And I think that's what was that final thing that made it this very specific niche. Like, I never thought it would be this. I mean, it's not like I woke up one day and it just kind of, that case changed me so much that then it led to all of this, I guess.
Yeah. And I guess for privacy, I wouldn't ask the details of the case. Yeah. Okay.
I mean, I can tell you again, everybody who's had one knows. It's, when I've talked to people, I've broken HIPAA, not at all. And they're like, well, I can imagine if it was severe, it involved this, this, and this, and I think, oh, yeah, like, wait, how did you know that? And so I think once you've had one, you know what I'm talking about. I think the biggest thing for me is I want to get to people before they have the big one, because I kind of wish I had known so much more before that one, versus being thrown into it and just kind of having to learn as I went.
Yeah. So how would you define Munchausen by proxy or medical child abuse? In a way, I think that's compassionate and also clinically useful. Yeah.
I think what we as a group or as a team of people that are working on this really want to focus on is that this is abuse and that it is a child that is being harmed. So again, we used to use, I think, Munchausen by proxy more because it really focused on that idea that the caregiver was doing it for attention towards themselves, wanting to be that sick parent. The reason they changed it to either Munchausen by proxy abuse or medical child abuse was this idea that no, the child is actually being harmed. This isn't just someone who's posting on social media that their child has something. This is actually physical harm, psychological harm. All these things are happening to the child. And what I try to point out, the definition probably could be 1,000 sentences long, but the words that I really try to kind of focus on is that this is intentional. At some point, this is not just an oops, I mixed up the story. This is not just we wanted one more scope just to make sure. There is an intentionality to it. And I think we'll talk a little bit more about that later. But we are learning more and more, I think, that it is pervasive. So I think medical child abuse may even change. If you were sitting in these meetings where we talk about terminology, it's like, at the end of the day, it's abuse, but we're realizing in the psychological realm, there's a lot of similarities where there may not even be a medical component, but there's diagnoses of bipolar, schizophrenia, or a lot of developmental delays are being reported. So things like, somewhere on the autism spectrum, ADHD, things that are getting these children extra accommodations at school. And so schools are recognizing this even, I think, sooner than the medical population. But just to remember that it is being perpetrated and also perpetuated by the caregiver. I'm not going to take blame off the medical system. That is somewhere where I disagree with some of my colleagues, where they say a physician can't help it if a mom comes in asking for all of these things. At some point you can. And I'm not going to say I've been complicit in my history. Maybe that's why I am so passionate. But at some point, your gut, your physician sense, your diagnostic ability knows something does not sit right or it's not fitting right. At that point, if you continue to perpetuate it as a physician, if you do that one more procedure, at that point, I think that is where I think we have to work on maybe some of the physicians actually being held accountable. But at the end of the day, without the contribution of that caregiver to the story, the falsification, the intentional, even all to the point of induction, meaning they're actually like putting bacteria in a central line, it would not happen. So again, this child is blameless. And I think this is a hard piece when we maybe meet the child when they are already a teenager and maybe already bought into the story, have already taken on that sick role. But remembering that at the end of the day, the parent is the parent or the caregiver is the caregiver. They are the ones signing the consent forms. They are the ones seeking out that next doctor. They are the ones, who are allowing their child to not go to school or whatever it might be. So really trying to separate child from caregiver in this scenario, but remember that the child is being harmed usually in many ways throughout their life, expanding to all of their little life circumstances. They may not have friends. They may be held back from social engagements. So that's what I always try to do is kind of bring it back to the child whenever I may find myself getting frustrated or wondering like who's doing what to who, like take it back to the child.
And have you looked into or researched about, why does it happen?
Oh, yes. I think the problem, or maybe not the problem, I think what makes it more complicated is that I think there's multiple ways to get there. The one we all hope it is that it was an overanxious parent who was dealt with some kind of a medical symptom diagnosis. Maybe their child did have a NICU stay. Maybe their child does have asthma. Maybe their child did have a seizure early on. Whatever that kind of instigating event is, just really overwhelms the mom or the caregiver's own anxiety. And as a result, they are constantly searching for the definitive answer that is going to say their child is okay. I think where it goes awry is when they start searching for the answer that maybe isn't that everything is okay, they are searching for that more extreme, more severe diagnosis. A good result is no longer a good result. They're looking for the other. And I think these are the ones that we found are the most treatable or the most, I guess, reversible or treatable, meaning these parents, if you take them back to the beginning and really work on their anxieties with the health system, getting them a PCP who really works with them, and having a family or a community kind of surround them and give them all the resources, those are the ones we think we can kind of flip or go back the other way, especially if it's recognized early. I think the concerns we have is that there are the ones you hear about in the news, the ones maybe you've had in your own career, where if a parent themselves has like a cluster B personality disorder, narcissistic personality disorder, borderline, where there is that attention-seeking component to their personality, with TikTok, with social media, with blogs, with GoFundMes, the secondary gains like abound on the internet. Some of my colleagues who are like the first generation of people who worked in this are like, if you'd have told us social media was coming, we'd have bowed out so long ago. Because it's just this whole world where they can get every piece of information they want and get the attention they want. And so those are a lot harder because once they are getting that attention and getting the secondary gain, everything else kind of falls away. And then the most severe, and this is where we get a little bit out in the weeds, but I do see it, is the idea that female psychopaths, female serial killers, think about it. They're nurses, right, who are killing their patients. There have been foster parents who are, killing multiple foster children. And so you have the Eileen Wuornos, who was kind of a very big outlier in that way. But if you are giving a person who has psychopathic tendencies access to a victim, and then the ability to harm that victim with their own kind of wiles and intelligence and how they're kind of having to dupe people and tell these stories, you can see how that can be honestly deadly at the end. But so I think there's a lot of different ways to get there. And I think that's what we have to, if we ever want to stop it before it starts, we need to figure out which of those we're dealing with. But once the child is being harmed, I think the management of that child as a physician is similar, I guess, in how you actually care for the child medically.
Yeah. And how would you, I guess, this is fascinating, terrifying at the same time.
I know. Trust me, like every night I lay in bed and I'm like, oh, like especially if I talk to somebody that day, it's just like, no, my God.
Yeah. But I was going to say, so what are some of the early red flags that we can see as providers? And you said something about over-anxious caregiving. It sounds like that would also qualify as Munchausen's if it reaches a point, or no?
Reaches a point, I think, where if the child is actually, right, if they're just, they want to go see another GI doctor because they still feel like their child's vomiting, I think all of that falls within reason. Sometimes I wish, and I've worked with lawyers and law enforcement. We all want the same thing, I think, but we have different language in getting there.
Mhm.
But the truth is, like in the legal system, this idea of reasonable cause or reasonable suspicion or whatever that word reasonable means, it's like once it goes out of the realm of reasonable, like if you put 100 parents in a room and ask them what would they do in this scenario, when only one or maybe none would go this path, it starts to hit that unreasonable point, And I
Yeah.
think that's where an over-anxious parent, when it becomes intentional, when you can start to see not just visits lining up, but medications and procedures, and then the behaviors start to escalate too. If you don't do this, the behaviors escalate. They move on to the next. And those intentional actions like blocking medical records or purposely leaving out a huge part of the story or things like that, that's when I think you have to just tell yourself, okay, maybe it started there, but we're kind of way past there at this point. And to your question about red flags, I think some of it is, I mean, I hate to say it's like the spidey sense of a doctor, but if you've been doing this long enough, you know when things start to maybe just feel like they don't quite make sense. But to put it kind of in terms I think we all would understand, it's the idea of you walk in the room, and I don't know how you do it, but like I look right at the child regardless, and kind of you can see a lot just walking in a room. And when that child, if you are talking to them, if you're interacting with them, they just don't fit the story. They appear either less sick or less developmentally delayed than what is being reported. If you're a teacher, if you're a school nurse, you know what a normal 6-year-old comes in looking like, right? You know what a child who's severe on the autism spectrum looks like. So why isn't it lining up? Why is it different than any other case you've seen? And I think there's a discrepancy, especially if you had the ability to look in the medical record before you meet the child or review medical records before, where then you come in already with some knowledge of what happened, and the story that's being reported to you is so drastically different than what was in the medical record, or the severity seems drastically different. I had a case where it was not forgetting how much they weighed at birth. It was at a 2-week visit. The mother was already reporting that the child had a hypoxic event at birth, required CPR, resuscitation, was in the NICU. And when you review the birth record, it was like APGAR's 8 and 9, normal birth weight. This is not, and maybe it doesn't always start that early, but when it does, like that intentionality was there from right off the get-go. I think the extent of the medical assessment. So we have all repeated a CBC to make sure that, the hemoglobin really is what they say it was. Or we've all maybe done one more ultrasound of the gallbladder to make sure there really aren't gallstones. I think it's when you start seeing this pattern of multiple normal assessments, yet we keep repeating to find that they're not normal, or the assessment does not line up with the symptoms. I've seen a child who has norovirus and a day of vomiting and like terrible diarrhea. Their labs are all over the place in one day. I've also seen them where they're relatively normal. But when you're reporting to me 3 weeks, has not tolerated anything by mouth, can't even get her to drink water, and her labs are completely normal. Like, we went through a lot of school. Like, remember, at some point, things should make sense, not continue to not make sense. And I think in the world today, I'm going to scare you again, but there are always doctors out there. This is what scares me, that will give potentially the answer that someone is seeking. There are clinics that do specialized testing for certain diagnoses that they don't release the actual results, but they release their interpretation of the results. So these things, you can see where there are very big slippery slope into this world where now you're labeling children with diagnoses that you really have no objective data from. And I think that doctor shopping is something that gets a little bit misconstrued. I've had people say, oh, so if you're the second doctor I see, you're going to report me for medical child abuse. No, that's not what I'm talking about. But I have to be honest, if I admit a patient and we are the fifth hospital in Florida to see them for the same, or they're from Texas and are coming to Florida to be seen again, I'm thinking, what was it about the entire state of Texas that you couldn't find someone, right, to give a diagnosis? And I think there are always going to be those hospitals that everybody knows. If the hospital is the specialty center and a special diagnosis, I understand how that happens.
Yeah.
But when things start to get out of that word reasonable, or if you look at everything in totality, the timeline starts to go like this and things just don't line up. Remember, especially, and I think this is why I was really maybe bad at it early on, is you want to trust the people that went before you. You want to believe the parent is telling you the truth.
Right.
And so it makes it a lot harder until you kind of can step back and look at it, objectively as a whole and say, okay, what are the pieces that just aren't lining up?
So, may I challenge you for a second? I was thinking, there's like so much, and I understand, I get all of that, and I get where you're coming from, but there's like so much ambiguity, and medical science doesn't have the answers to everything, and sometimes we don't even sometimes the symptoms are real and we just can't figure it out. There are those cases where the symptoms are real and there's medical gaslighting too. So how do you differentiate that? Do you think there could be that their symptoms are real and we just don't have the answers and that's why they're going, or yeah?
I think, of course, and I think like I said, being the third children's hospital in Orlando, I do think right off the bat, we did have a lot of families coming in with the binder of this is everything that went before, now figure us out. And I will say that in that first year, we did make some diagnoses that these families did not have before. And it was that we had the first pediatric rheumatologist, I believe, in the area. So there were things we found that were not found before.
Yeah.
And again, I think to make a point to what you said, having a medical diagnosis also does not mean you cannot also be a victim of this, which is going to get more convoluted, I think. But if anyone is familiar with the Maya Kowalski case, that made the Take Care of Maya movie on Netflix, she reportedly had complex regional pain syndrome. But at the end of the day, for me, whether she had it or not, there came a point where the treatment being sought by the parent, the things the mother was signing consent forms for, a ketamine coma in Mexico with a 50% chance of death, and she signs the consent form. The things she was writing in the blog compared to what she was presenting to the doctors, what was being told to the church for donations versus what is being told to the doctors, there can still be differences in that. And I think for me, what I try to tell my residents and my learners is, if you are considering the rarest of the rare mitochondrial disease, right? The rarest of the rare genetic condition, just don't not have this in the back of your mind. Like, don't act like it does not exist and is not even a possibility.
Yeah.
So considering this does not mean you stop considering other things. It's just, I think you do it maybe with a little bit more of a team-based approach, more of a open mind to how things are going.
Yeah.
And know that when the answer is no, though, like to some extent, the answer is no. I think mitochondrial disease, it's funny. I always go back to, you guys remember like red ragged fibers, right? On a muscle biopsy, right? So I'm not going to say every person who suffers from mitochondrial disease, if you do a muscle biopsy, is going to have that.
Yeah.
But if they are weak in their legs to the point they are not walking and their muscle biopsy is normal, even if they have a genetic marker for mitochondrial disease, it's not causing the leg weakness, right? So it's still kind of teasing out what parts are part of it and what may still be, kind of escalated above that, if that makes sense.
Right. Yeah, that makes sense. And you talked about, the movie on Netflix, and I was just thinking, what about how, when you're trying to make the diagnosis, I think we have some discomfort. Me personally, I always think, what if I'm wrong?
Right.
And that's like the biggest thing. Then I guess I'm getting this process started of getting somebody accused of something, which may be wrong. So how do you deal with that discomfort? And I think, how can you approach it if you start having a suspicion?
I think the biggest thing that we are working to, and that I see, actually, I've given grand rounds at quite a few children's hospitals. I'm honored to, especially at some of these really big facilities that have so many specialties that are kind of renowned for being kind of implicit or involved in these cases, I think, is the team-based approach. Because being a silo or being the one person who sees it is a very dangerous place to be right now. And, I've had a colleague of mine say, "Will you come on service tomorrow so you can call it in?" And that's not fair, right? I mean, we can't do that. Or, I mean, that is an absolute setup for one person to be thrown under the bus. But the more we can have team discussions, and I think the more we can work as a team early, that is protective. So having one of the things we're working on, so in the electronic medical record, is this child is at risk of overutilization of the medical system, right? We kind of know that there's that little something that tells us they could up and move on to that next facility, or they could get that next procedure. And so you want to make sure that everybody involved in that child's care, to whatever point, is communicating with each other. So there's not going to be that one physician who kind of goes rogue and goes off. And I got real excited, almost knocked everything over. But like, that's going to go rogue and place the G tube, even though there have been multiple conversations about, let's do this, this, and this before we place the G tube. So I think that team is protective. And if you are able to have a team, even within your community, with DCF, with law enforcement, just with everybody knowing and everybody being educated and everybody maybe trying to speak the same language, we can do so much before it even gets there. I think that moment where if this doesn't change, something is truly going to happen to harm this child, I would hope that everybody would be calling it in, right? Once you're like at that point of no return, they're in hospice care, something, that point. But being able to communicate and talk about it so much sooner than that, so that even as we are working up all these other conditions, you're still communicating and making sure that everybody is aware, that everybody is kind of, and if we all sit in a room and talk and we're finding that everyone's getting a different story, that, there's different pieces to this, again, it's protection in numbers, but it's also so beneficial to the team to know that someone's not going to kind of undermine the whole story, the whole situation. I think a weak link is very dangerous in any complex case, because if they're getting different stories in any of these, any case where a child's undergoing a big workup for something, that is the most frustrating thing for any parent, is hearing multiple stories about the same thing.
Yeah. And I'm assuming, so you get your team involved in, you usually keep it private from the family, or how do you approach it with the family?
I think this is hard for all of us. And I started to realize, I think at the end of the day, the reason this abuse is so controversial, so difficult, is it goes against every tenet of pediatrics, of advocating for child advocacy, of family structure, right? It goes against all of it. I just had this conversation with some of my friends, like physical abuse and sexual abuse. We went through medical school learning about those things. They are devastating. There's a reason I don't do child abuse pediatrics. I could not do that all day, every day. But I know it exists, and I know what we do when we see it. This, I think, it is so pervasive, and it makes you have to question everything you know and everything you want to know about about healthcare, that we could be complicit in this, that we could be lied to, that a child could be being harmed under our watch, that we could have prescribed the medication that the mom stockpiled and gave to the child, that we ignored that red flag of something truly being wrong and assumed it was this. And it makes us question, I think, who we are so much and what we do, that people ask me, well, aren't you just jaded now and cynical and you assume it's everywhere? And I said, no, it's that I saw it and I can't unsee it. But I have the benefit of working at a hospital where I'm never alone. So I can also stay grounded. I round with residents, med students, nurses, pharmacists, so I think I've gotten to the point where I never let it come out of my mouth first. I can't say that maybe my eyes don't do a little. I try to wear a mask, so I don't even make a facial expression. But when a student brings it up in their differential, when, someone asks the question, I'm open to it. And it is a really hard place to be, but I've become the office where people from everywhere around the hospital will just knock on the door and be like, hey, can I run something by you, And I always tell them, if you're running it by me, you have suspicion, you have concern, right? And so I just want to kind of make it a point that I don't want things left on me for a child that I've never met.
Yeah.
But that they're going to tell me a story where I do think something, you know what I'm saying? I can't talk about losing sleep. I would never sleep if I had to take on all of those as well. I don't know if that answered it, but I think it's, I think we do have to stay grounded in all of it. And that's where I think anytime you can have a team, anytime you can run it by someone else, I think is important. And if you are at the point of reporting, I think having as much information as you can. There is something to be said for if you, GI, and neurology all have concerns, sitting and making the call together, or if you're doing it online, saying these other physicians also are available for, information. I just think having all your ducks in a row, and I have never called DCF on anything without pausing.
Yeah.
Or hesitate. It's never just just pick up the phone and call, right? It is not like that. I always do my double checking. I think you want to know when you make that call that you're making it for a true, a reasonable suspicion.
Right. In communication with the families, so I guess when you talked about, ordering the other test, or, when you're trying to do that. So how would we communicate with the families if we have suspicion? Have you had experience with that?
I have. And I think I've had it in a lot of different ways. I've had the families that don't want you to do anything. You know what I mean? They're like, no, we don't want this. We don't want this lab. We don't want this. And so it seems we are better at having that conversation of why we want to get that CBC to see what the platelets are today. Why, those kind of things seem to go much easier. It's the saying no, I think, that is harder for us. And I said it's a slippery slope for what's one more abdominal ultrasound. It's not radiation exposure. It's not that, right? But it is fulfilling this, that you do still think as a physician that something is wrong. Yeah. I sat in a conversation once when we first opened. We kind of covered all the kids in the hospital. It's been a bit of a roller coaster as to what the hospitalists cover, I'm sure, as in many hospitals. But there was a time where we were covering hem-onc patients, and I sat in on an oncology discussion with one of our oncologists, and I was blown away because it was I had actually, of course, been on service when this child had been diagnosed. And then here I was years later there when it had kind of reached end stage. And seeing a parent physically lunging, at the oncologist, basically saying, you will do more. Like, you won't stop this chemotherapy. You won't, all of these things. The oncologist stopped and just in such clarity said, I am not saying you cannot go seek out, like, I would never tell you that. You're the parent. You want to find some trial, you want to enroll them in something, I would never get in the way. You want to go see somebody else, I would not be offended, but I could not do what I do unless I also have the ability to say when we stop, right? When we stop doing this part of the treatment, like, I am doing more harm than good at this point. And I just remember thinking, I could not be an oncologist. Like, because I don't know that I could find that level. One of the benefits of being a hospitalist is, well, you can always keep them one more night. You know what I mean? Like, there is that feeling. So I think it's partly why I do it. But also, I think when you are talking behind the scenes about all the reasons doing another MRI makes no sense medically, that's what you have to go into the room with. You have to explain it with conviction. And I will also tell you that any opening, if it truly does prove to be one of these cases, they will find that opening and they will jump on it. They will find the one GI provider who will do that study. So being a unified front, if you can go in the room with the GI provider to say, we are not doing this study, if you can go in with their PCP on the phone to explain why you are stopping this medication and they won't be going home on it, anytime we can be a united front. And I think go in, if you would say it to another patient's family, you can say it to this family too, right?
Yeah.
Like, we are so much better at talking to the nice families, but that's also not right. Like, I compare it. I think I just gave a talk where I said, I had a child who was autistic who was starting to have, I'm sorry, they were in the outpatient ward. It was not my patient at this point, but swallowing difficulty, changes in voice, unsteady gait. And mom just kept being told, well, he's autistic. And she said, right, but he's not that autistic. And he is 16 and his autism has not changed. So I'm concerned why it would be changing. And she fought for him and fought for him. And it took 6 months to get an MRI that showed he had multiple sclerosis. Compare that with this family who has had 3 normal brain MRIs in the last 6 months. And you are talking about doing another one because then mom will agree to leave. Doing another one, that is not, we cannot be doing things in any situation just because the mom wants it, or just because the mom is threatening, or just because we're concerned about getting sued. There is a reason we have a standard of care and a reason why, if you talk to your whole team and no one would do the MRI, but you're the lucky one who gets to go in and say you're not doing the MRI, like, remember what we're doing. Like, we don't change who you are or what your standard would be.
Yeah. Yeah, that makes sense. It's hard though. It doesn't. It's so hard.
And I think I found myself maybe becoming more honest, maybe to a fault, but where I will say, mom, that concerns me a little bit. Like, I understand as a mom where you're coming from, that you want more answers. But it does concern me that that there have been 3 normal ones. Like, I'm just trying to understand why those 3 normal ones weren't enough. Or, like, tomorrow, if this one was normal, would you want the biopsy to prove it's, you know what I'm saying? Like, already kind of telling them, I'm already concerned that we're here. So how did we get here? And try to get them to kind of explain it more, which I think, to your point about just the over anxious parent, you may open a floodgate as to why they are, doing so much too.
Yeah. Yeah. And about documentation. So if you're suspicious, should we be documenting that, or unless we're sure?
I'm learning more and more as I go around the country that every place has different policies. Every state has different policies. But the electronic medical record is both a blessing and a curse.
Yeah.
So they make us be more detailed in certain ways, but it also allows us to be very vague in others. I worry about transparency of medical records. I don't want to get political. I understand why it has to be. My concern is when your patient is a child, that the transparency is not to the patient themselves. The transparency is to the caregiver, which I understand why that is necessary, again. But what about any case of abuse where we are at our heart, at our oath to be advocating for the child, but putting something in writing could actually be harmful? So if I say, I do not suspect this was a seizure because the patient maintained consciousness, did not change color, vital signs remain normal. When I walked in the room, he turned and looked at me, right? I'm writing all that stuff. But I'm also giving a parent the playbook for what a seizure should look like the next time, right? Like what it would need to be for me to be concerned. So it's kind of that plus, if you know they are maybe going to go to another doctor next, how do you write the words that I'm not at the point where I think this is abuse, but I'm starting to see behaviors. And I think this is where we need to have better language around it and better objective language around it. And I think we have to have more ways to protect ourselves in the electronic medical record, that if CPS is requesting, if courts, if law enforcement, if another provider is requesting, that that the chart would move along all of it in its entirety. But there has to be a way we can document concerns for the child that would not immediately get in the hands of the potential perpetrator. I think if you're at the point where you are saying medical child abuse, Munchausen by proxy abuse, physical harm to the child, it is very risky to document that and not be calling it in. But if you're at the point of seeing the behaviors, document the behaviors and try to do it in a non-accusatory, non-inflammatory way. So I walked in the room. There was vomit all over the blankets. On assessing the child, he's laughing, playing on the phone. No vomit seen on the onesie or on the, right? Like, mom is crying at the bedside. Again, you're not saying this could be a very valid episode of vomiting in the bed. Of course it could. But when that happens every day and you're saying, walked in the room, mom reports, MS, this happened immediately before provider entered the room, right? Or a seizure happens every time you take off the 72-hour EEG. By documenting that, you are documenting something that does not, right? That maybe doesn't always line up.
Sure.
But you're documenting it. You're documenting, as when I mentioned the chance of a swallow study that could allow the child to eat by mouth and no longer require the G tube, mother became tearful and angry, stating she will not, allow this study to go forward. It was explained to mother that he's had multiple G tube revisions and procedures, that a swallow study only involves this and this. And he was seen eating his sister's chips when we walked in the room. Again, I think most physicians would read that and think, well, wait, that doesn't make sense. And so, but I wish there were, I think, more safety nets. It's frightening to think how we used to document. I was a med student resident where I was handwriting notes, and God knows what the attending wrote on there. But I do think in my case that changed everything. The electronic medical record saved that child's life, honestly, in my opinion, because I was able to see everything that came before. And I was able to search and make a timeline of how things played out. And so I can see where the medical record can absolutely be a game changer. But I can also see where it feels risky to put things into writing sometimes.
Right. And would you be expected to, or did you go to court or be involved in the legal proceeding if you have documented once the CPS and legal team gets involved?
I think anytime we do, we have to consider that that's a possibility. In many different ways, I think I've had colleagues, people at our hospital that have had to, because of how things have played out in my cases. I have not ended up in, I don't even want to say that. But I think One of the things I did learn from the Kowalski case, again, because I watched the trial in its entirety, was how much they can nitpick the medical record, how much copy forward looks a certain way in court that I never thought about before. When we're an attending who is writing agree with the below as documented by the resident, we just took on all legality for that note. That means we are agreeing with every single thing written in that note. If we say we examined the child that day and we do a dot phrase for a physical exam, that is the physical exam you did that day. So they can nitpick down to the letter. So they can also come and say, well, if that happened that day and there wasn't a seizure then why didn't you say there wasn't a seizure you witnessed, or, whatever it might be. And so that's where I think being thorough is so important because of what it could mean. I have a friend who is a CPT physician, meaning they work for the state and do the medical abuse evaluations. And they said the most frustrating thing is when you request thousands of pages of documents and not one person documented, any concern whatsoever. When you call these people and talk to them, they're like, oh yeah, it was Munchausen. But you're like, great. Well, and so I think even but a CPT physician will be able to read when you're documenting the behaviors, when you're documenting the discussions. I had a case where I was educating the family. We'd done a stay in the hospital where the child did not need their G-tube the entire time. When they left, I made sure that I had a resident with me, I had a nurse with me, and I had our discharge person with me. When I told mom, look, we have shown she did not need the G-tube here. That being said, she is going home with the G-tube. What we would recommend is she does this during the day, she's eating this, she's taking these medicines. You don't need to use the G-tube if she continues to do as she is doing. However, if she has a day where she doesn't do this, you can use the G-tube. This is what you would do if you used the G-tube. However, if for 3 days you're needing to use the G-tube, that would also be a bit, of an outlier according to what we're seeing. So you should be contacting GI. We wrote it. We told mom. We made sure it was kind of in the discharge paperwork. Presents to GI 2 weeks later saying, Dr. Gill told me she doesn't need the G-tube, so I didn't use it. And, she comes in having lost weight, all these things. But they could go back and say, okay, but on your discharge paperwork, it gave you, the recommendations for how to use the G-tube. And so just having that there, again, for what it's worth.
Yeah.
I don't want to document just on the basis of I'm scared I'm going to get sued. But documenting what you did say and what you did educate on can go a long way for that next provider.
Yeah. And I haven't watched this documentary on Netflix, but wasn't there a documentary in which the diagnosis was wrong? Was that this documentary or no?
It's hard to say. So I think the documentary was made prior to the court case that ensued. And so the information that was had at the time of the documentary was actually the villain of the documentary was actually the CPT physician or the child abuse pediatrician,
right?
Dr. Smith, who I've actually met and spoken with and
yeah.
It is a one-sided documentary. I will say, nobody from the other side could talk or did talk, but then by the time that it went to trial, it was that Johns Hopkins All Children's was the villain. It came out all against the hospital. And that ended with the verdict against the hospital. So $260 million against the hospital for all of these reasons. Just a couple weeks ago, that entire verdict got reversed to where there is now $0 out there. Everything got reversed. There are a couple points that could go back to trial potentially. But I think the thing that really came out in all of it was, at the heart of it, there was a report made for suspicion of Munchausen by proxy abuse. That is what the hospital did. From that point forward, it was a court order to shelter her in the hospital. It was court orders on visitation, court orders on, right? It was all of these things that kind of came because of that report.
Mm-hmm.
And so what Johns Hopkins All Children's actually did versus what they had to do based on these court orders. And I think what I appreciate, I'm not saying there aren't a couple counts that need to go back and maybe be retried, but I was extremely concerned with how it was portrayed, that reporting a suspicion can be turned into a false allegation, then leading to all of these things for the child. I mean, you never report a suspicion of abuse without it being a hard moment for this right? I mean, like, it's never a great moment in their life, right? It's
Right.
never
Right.
going to be a positive thing, and so the appellate court really took it back to mandatory reporting. And I think for me, that was important because people were not reporting because of it. I can tell you in the state of Florida,
Yeah.
people were extremely concerned. And I can speak to hospitals being extremely concerned about quote, opening a can of worms or potentially going down that same
Right.
route.
Yeah.
But when they did, one thing I was impressed by with the physicians from All Children's is they did stand behind their documentation. Like, they were not getting on the stand talking about things that were not documented in the chart. I'm sure that's because they were told you can't talk about things that you didn't document in the chart. But there were things documented. And I think I learned a lot. I actually gave a grand rounds at my hospital just about documentation in general. Document what you did do. Don't document what you didn't do. If it's on your differential, it should be documented that it is. But also, I think being upfront with the family and saying, there are things that aren't lining up. I'm trying to figure that out. So while we are doing this, I want to let you know that I am also looking back at old records and trying to figure out where this diagnosis came from. And so being upfront, I think, remember that blocking medical records in the electronic age is more of an active process than a passive one. So,
Mm-hmm.
like, our general consent involves access to the electronic medical record. In
Yeah.
order to block that, you actually have to go and you have to file forms and you have to state reasons to be blocking the record. So
Right.
just remember that is a little bit of a red flag in and of itself if
Okay.
they are choosing to actively block access to previous things as well.
Yeah. How do you? I think we're almost going towards the end. This is
Oh, I
very.
mean, I should have warned you.
Yeah. Yeah. No, I wish we could talk longer. It's very interesting, and I'm learning a lot. But how do you deal with that? Just, I guess, emotionally, and obviously, it takes a toll on you. It sounds like, and anybody I know it takes a toll on me when I have to make that call. It's very discomforting. I'll say so. Yeah.
And I think, I mean, that case changed me, I'll be honest, in a couple cases since then. I think one of the hardest things I went through was having to actually process that I know I had been complicit in the past, not intentionally
Mm-hmm.
complicit,
Yeah.
but that I do believe that I had missed it places along the way, or I didn't know to question. I lost some friends in the hospital during that case who basically told me, this mom just loves her kid. I don't know why you guys are going to this extent or why this is even happening. I realized how little I knew about the process, about who is involved on the end of, DCF or CPS, whatever it's called in your area, how important it is to know your state's laws, your hospital's stance on all of these things. And there were days it felt like it was just me. Like, people were like, oh, Rebecca, you're just, and it felt, oh, you're just the crazy one. It's all the things. You're the crazy one. You're the one that you dug into it. Now you have to deal with it, kind of a thing.
Mm.
But I also know without that, no change is going to happen because it's getting worse with all of the things involved with social media and the internet. And there are now adult doctors who don't even see children, who are opening up their doors to children and allowing parents to bring them in to have these treatments and things like that. I struggled a lot. I mean, when I think back to those 3 months specifically, I'm not sure I saw my children very much. I was very deep into it. It was always on my mind. And I was stressed to go to work. There was a lot that I didn't understand. And I mean, I give credit. I ended up listening to this is how I ended up listening to the Nobody Should Believe Me podcast to like the first 2 seasons. I reached out to Andrea and I just said, who's the the host of this podcast. And I just said, thank you. Like, thank you for having this there, because listening to the first season, I was like, okay, there's better ways to do this. And she put me in touch with Mike Weber, who is a detective who works in these cases, and then with a survivor. And I had the opportunity to speak with both of them. And I remember Mike Weber saying to me, you don't have to break HIPAA and tell me anything about your case, but I will tell you if there was the extremes of TPN, G-tubes, hospice care, pain medications, worsening seizures. He listed off all of these things. He's like, if even one of these is true, you were probably past the point of no return for this child. And it was going to be miracle cure or the child was going to die. And you need to know that there does come a point where it is life or death and you did the right thing. And he said, you saved this child. And I was like, whoa. And he told me more about talking to the perpetrators and interviewing them on his end. And I was just floored by some of his stories. What the survivor told me was, just keep going back. They said, it's not going to be easy. The patient is going to hate you some days because they're going to see you as the villain too. But you have to be okay being the villain in order to get to the other side. And they said the kid may not realize it today, but someday they may look back and realize what you were trying to do. And for them, it was reading their pediatrician's notes years later as an adult, realizing that they were trying to do certain things and that they did call it in, and that they did care. That kind of changed everything. And so my patient still comes back, will like give me hugs. Okay, you know what I mean? Say thank you. I'm not sure they process exactly what they're thanking me for. But they did say they were just glad that we cared about her. And so for me, that is what kept me going. Again, if it had a different outcome, Lord knows where I'd be. But then the Kowalski case happened the next year, kind of right down the road. And that's how I ended up on the podcast. And you may laugh, but I don't know why the light just flickered, but I liked the podcast because I could just talk and not have to be seen.
Oh.
And then all of a sudden, Andrea was like, let's video it. So, but that opened it up to now I can actually go out and public speak because I've gotten more, you know what I mean? So I think this is what I do now to get through it. But I think shared experiences are huge. When I'm speaking and I see nodding heads, it keeps me going, honestly, because that means those people didn't feel like someone else knew or heard. And so the more we talk about it, I think for me, it's those shared experiences. Every talk I've given, someone comes up to me afterward and wants to tell their story. I have to be careful to let them do it during my talk because then it's like, oh my gosh. But afterward, I encourage it. Like, I will listen to your story because sometimes we can sleep at night knowing someone else heard it and was like, no, you did the right thing, or it could have gone this way. And like for me, hearing that it was really a potential life or death and hearing that just being there may make the difference in the long run, I am so grateful for that. And then that Andrea gave me a voice kind of to be able to, because often physicians can't talk. And I want to give credit to all the people who have been involved in a case that can't come out and talk, and that their organization puts out the blanket statement on behalf of everyone. That is not to say these doctors are not sitting in their offices screaming, wishing they could tell their version. And so that's why I do it. Like, I feel like if I can talk for physicians in general, Even
Yeah.
if you don't agree with everything I say, I think it's just to give a voice to the people that, may be involved in something that they can speak out on.
Yeah. No, thank you so much. I think it's very important, and you're talking about things that we don't talk openly about, and those are really hard. And just having the courage and vulnerability to come out and say it, because a lot of those things, you worry about, if I say this, and just saying it out loud, and other people listening. I think listening is an act of feeling okay, when you can connect with what somebody had said. So I think that's why sharing is so important. So thank you so much for being with us. It's really nice to meet you as well. We have a tradition on this podcast that we end it with a poem. So I had a hard time finding a poem for today, but it's a poem about worrying, and it's I guess it takes the load off us a little bit. So as we work in emotionally charged fields like medical child abuse, it's easy to hold everything tightly. The fear of missing something, the uncertainty, the responsibility. And this poem reminded me that worry isn't what keeps patients safe. Attention, collaboration, like you talked about, humility, and just compassion do. So it's called "I Worried" by Mary Oliver. So I worried a lot. Will the garden grow? Will the rivers flow in the right direction? Will the earth turn as it was taught? And if not, how shall I correct it? Was I right? Was I wrong? Will I be forgiven? Can I do better? Will I ever be able to sing? Even the sparrows can do it. And I am, well, hopeless. Is my eyesight fading, or am I just imagining it? Am I going to get rheumatism, lockjaw, dementia? Finally, I saw that worrying had come to nothing, and I gave it up, and I took my old body and went out into the morning and sang. Thank you so much, Dr. Bex, for doing this with us today.
I have all these things on my wall behind me. It's like all these quotes from songs and things. I think I'm going to put that poem up on my wall.
Yeah.
I love it.
Yeah, no, thank you so much.